So we all know that conduction system disease is a frequent complication of aortic valve replacement, whether it is either surgical or transcatheter aortic valve. So this is because it is due to the close proximity of the conduction system to the aortic valve. So the ideal pacing modality has not been defined yet, but we know when it is an RV conventional apical pacing, it leads to a pacemaker induced cardiomyopathy, heart failure, atrial fibrillation burden. When there is a patient who had an existing LBBB with RV pacing may lead to adverse outcomes. So the studies, materials and methods, the aim of the study is to evaluate the feasibility and the safety of the conduction system pacing post aortic valve replacement, whether it is either surgical and transcatheter aortic valve. The study period is December 21 to till present. The study design is prospective observational study. What we are going to see here is the data and the indication of how we took the patient and the conduction system pacing, whether it is his bundle pacing and or left bundle branch area pacing, and the usage of leads, whether it is lumenless leads or it is a stillet driven leads. So what are the characteristics we assessed? It is the baseline, the procedural characteristics and a mean follow-up of 6 months follow-up characteristics. What we assessed is LV ejection fraction, QRS duration, pacing thresholds, sensed R waves and pacing impedance. And if there is any complication, that is acute procedural complications or chronic complications. The study population includes patients with an indication of permanent pacemaker implant post aortic valve replacement, that is either by transcatheter or surgical aortic valve replacement were enrolled in accordance with the ASC guidelines. The informed consent are obtained. So this is our baseline characteristics of a study of a total of 15 patients were included. So this is our study variables where we had seen the mean variables of age of the patient is 63 plus or minus 4, and the female population of 33.3%, LV ejection fraction, mean ejection fraction is 45.5 plus or minus 10.6, surgical aortic valve replacement is 13, that is 86.7% of the patients, and the transcatheter aortic valve replacement is 2, that is 13.3%. When it comes to the result, the his bundle pacing is 26.7, that is 4 patients out of 15. The left bundle area pacing is 66.7%, that is 10 patients. There is one septal pacing. The lead we used is the lumenless lead of 383069 centimeter from Medtronic lead were used, that is in 86.7% in 13 patients, where the stylet driven leads were used in 13.3%, that is 2 patients. The acute procedural success is 93.3%. The procedural time 88 plus or minus 11. Fluoroscopy time 39 plus or minus 20. So this is an indication of permanent pacemaker implant where the pre-aortic valve replacement, the patients are mostly in sinus rhythm, 13 patients 86.6% and 1 patient with a first degree AV block, that is 6.7%. When it comes to post-aortic valve replacement, the patients are went into sinus rhythm, the left bundle branch block 20% and complete heart block with junctional rhythm, complete heart block with the LBBB escape of more than like 6 and 4 patients, and first degree AV block remains the same in 2 patients. So this is our procedural characteristics where we didn't have any complications or acute complications we had, and there we can see there is 4 his bundle pacing and 10 left bundle area pacing and 1 septal pacing, and 2 of the patients are done with stylet driven leads. So this is our follow-up. We did the follow-up calling the patient. We used to do the ECG guided programming during the discharge and then calling the patient after 1 month, doing a complete ECG guided programming, then followed by a 6 months device check where we can able to appreciate what is the pacing thresholds or what are the impedance, what are the pacing characteristics and what we can able to achieve a narrow QRS with the patient. So this is our variables. During the implant, we are seeing the pacing thresholds. The implant value is 0.64 when it comes to the follow-up of 6 months where you can able to see 0.63. There is not much change. The pacing impedance 758 and the follow-up it is 680 ohms. The sensed R waves 10.5, the follow-up value shows 10.1. The LV ejection fraction, there is a slight improvement or a mean follow-up of LV ejection fraction from 45.5 to 46.2%. When it comes to the QRS duration, the basal QRS is around 150 millisecond during the implant, after the implant, where we get to achieve a narrow QRS 114 plus or minus 16 millisecond. When it's in the follow-up, it is like 113 plus or minus 15. So this is one of the case examples. It is a 70-year-old male, a case of diabetes mellitus, systemic hypertension, status post CABG, 4 graphs, 2002, echo findings of a severely calcified aortic stenosis, moderate LV systolic dysfunction. So where the patient went for a status post, it is a transcatheter aortic valve using MyValve Pro Merrill. So this is a pre-ECG of the patient, where we can able to see a narrow QRS, a normal PR and a normal axis, where this patient went into TAVR, the post-TAVR ECG, that is our pre-conduction system pacing ECG, shows a left bundle branch block. It is, and also the QRS is, as we can able to compare it from the previous ECG, that the QRS has significantly widened. Now the QRS is around 150 millisecond. This is a post-TAVR ECG, QRS of 150 millisecond. And according to the ESA guidelines, we post-TAVR, we took this patient. On the third day of the patient, we had done extended ECG of 24 hours Holter monitoring, showed a prolonged PR and also evidence of a second degree AV block. And we took the patient to the lab for the conduction system. The basal interval showed a sinus rhythm with the left bundle branch block, where we can able to see this is the pre-screw of the patient, where we are like pace mapping, where we can able to achieve a notch in V1 and also lead to positive 3 negative and also AVR AVL discordance. Then during the screw, we are able to appreciate this kind of a template beat during the screwing in the V1. So this is post screw, where we can able to see, where we can able to achieve a left ventricular activation time of 75 millisecond. There is a QR pattern in V1 and AVR AVL discordance lead to positive and left ventricular activation time of 75 millisecond. So this is the final AVI, where we can see there is a transcatheter aortic valve there, and there is an atrial lead and there is a ventricular lead deep into the septum. So this is a post ECG of the patient, where we can able to see a QR pattern, a left bundle capture and a narrow QRS post ECG. So the take home message is, the conduction system pacing is feasible in most of the patients post aortic valve replacement, whether it is either surgical or transcatheter aortic valve. The location of the aortic valve can also be used as a landmark for conduction system pacing. It helps to reduce the risk of heart failure and the deleterious effects of RV apical pacing, and also it has the potential of delivering a more effective ventricular resynchronization. Thank you.